Good morning. Thanks so much for inviting me. I'm really excited to be here. My name is Jasmine Reese. I'm an adolescent medicine specialist here at Johns Hopkins All Children's Hospital. I've been here since about 2016, and I'm the director of the Adolescent and Young Adult Specialty Clinic here. So I've done my training different places around the country. So I'm excited to be here in the Tampa Bay area and leading efforts in different things related to adolescent health care. So I am double board certified in pediatrics and adolescent medicine. And I also kind of wear a hat of training and teaching a lot of either medical students, pediatric residents, nurse practitioner students. So I also do a lot of teaching during the week.
That's great. I'm super happy to hear that you are involved in teaching, and I'm a little step removed from teaching, but I think it's great to kind of get involved in everything there. How did you get into adolescent medicine?
Everybody asks that question because most people are like teens, like, yes, go see this other doctor person about any of the teen issues. So I think, when I was younger, I always said, I want to be a doctor, I want to be a doctor. And then you learn like what a doctor is. And then I grew that kind of passion for medicine. And then I thought, well, I'm going to be a brain surgeon or a heart surgeon and all of these things. Then I realized that when I was in an OR, I felt like lightheaded. I didn't like being all covered up. I might pass out here for 8 hours standing. And I really missed that connection with people. I wanted to be talking. I wanted to be listening. And so I realized that really wasn't for me. And then I actually did a rotation with a pediatrician who was fantastic. He was awesome. And he taught me what my first HEADS assessment was. So that's like, that acronym we used to remember, the psychosocial history for an adolescent. And so he did such an amazing job with this teenage girl that he was seeing without her parent in the room and asking her all these like kind of private questions. And she was like nervous about asking anyone. And he got her to kind of open up and share. And I was like, this is the coolest thing ever. I want to be one-on-one with a teen to like help them make sure they're making good, healthy decisions. And so from there in medical school, I like made that decision like, oh my gosh, I have to do adolescent medicine. So I kind of like tailored my next steps of training to make sure that I could get that mentorship. So that's kind of how it started for me.
That's awesome. It sounds like you kind of knew earlier on in med school. I think that's different than some people. I was definitely a longer roundabout person on figuring out what I wanted to do, but yeah, I'm super excited about that. So today's topic is actually going to be eating disorders because you are super specialized in that. So could you tell us a little bit about what eating disorders are?
Sure. Yeah, eating disorders are really mental health diagnoses. So you can have like some disordered eating, which probably a lot of us aren't like perfect eaters and eating our like healthy meals throughout the day. But when you truly have an eating disorder, and what we're doing, like especially with our teens and kind of screening for an eating disorder, we're really thinking about, do they have a healthy relationship with food? Are they like purposefully restricting because there's this fear of weight gain, negative body image? And then it becomes almost this like obsession, right? It's like controlling my daily thoughts to the point of now I'm like not even functioning socially or relationships, academically. So it can really take over your whole life. So it's kind of like the switch goes on mentally. That's really, really hard to switch off, where all you can think about is, that kind of fear of eating or fear of gaining weight. And that in particular, usually it kind of describes something like anorexia nervosa, which is one of the more common eating disorders. So they are mental health diagnoses, but they have pretty significant and severe medical consequences. So we do use like the DSM-5 criteria when we're making these diagnoses, when we see teens in our clinic. And that is really like the mental health guidebook, right, that we always use when we're thinking about a mental health diagnosis. So they're pretty severe. And there are a few of the more common ones. So that would include like anorexia nervosa, bulimia nervosa. Another kind of newer one is ARFID, avoidant restrictive food intake disorder, binge eating disorder. So those are kind of the more common ones that we tend to see.
Okay, so by the time patients are probably coming to you, they might be a little more severe or advanced, right? Okay.
What I've noticed here in clinic, because I don't do primary care, we are like a specialty referral-based clinic. And so by the time they get to me, somebody has identified there's some abnormal eating relationship, and then they're like, go to this doctor so they can figure it out. And we've sort of grown a team approach because there's so many different pieces and things you really need to understand to be able to make that diagnosis.
Yeah. So how does that team approach work? Like who's involved in that?
So as an MD person, right, I'm really focused on medically, like how are you feeling? One, like how's your energy level? Are your electrolytes normal or abnormal? Because that can affect, all of your body systems, including your heart health. So I would be asking questions like doctors ask about like review of systems and doing the physical exam. And then I rely on our psychologist who is part of our team to really go through like any mood changes. And then our dietitian that works with us really goes through a very detailed recall of their diet history. What kinds of foods are you eating or avoiding or have fear of eating? And then we all kind of get together during the patient care setting and say, like, are we meeting those DSM-5 criteria for one of these eating disorders or not, so that we can help the family plan next steps.
Okay. You mentioned electrolytes. So I guess we're kind of pointing toward how are they actually dangerous? Can you describe more about that?
Sure. So one is just restricting severely can affect your electrolytes, but also thinking about like binging and purging behaviors or use of laxatives. So if somebody is, for example, purging a lot, you probably remember learning in medical school, like these shifts of electrolytes that can happen with sodium, potassium chloride. So that's one area. But then when you think of like, what are the consequences of those electrolyte shifts? And that really becomes like your heart health. The most important organ, right, is like you need your heart to live. And so that's what we worry about is, is this person having chest pain or palpitations? Do they need an EKG? So we always ask about those kinds of symptoms. And are you feeling like dizzy or fainting? And so your electrolytes can become abnormal. It becomes sort of the timing of things, right? So if you're not feeling those things and you have an eating disorder, it's like, well, I'm not really going to get that. And I've been, I had this eating disorder for months or years even, and that's never happened to me. But you're always at risk. So we're always describing this like really high risk of all of these bad things happening if we don't intervene and get treatment.
Do you do any inpatient medicine? Like, do you put anybody in the hospital?
So I don't work on the inpatient side, but we certainly collaborate with the inpatient team. And very often, unfortunately, we do have to admit somebody kind of on the spot. They might come in thinking this is just the routine visit. And then we see like a very low heart rate or abnormal electrolytes. And it's unsafe for them to really go home from that visit. So we would recommend admission to the inpatient side.
Yeah. So, I guess teenagers tend to be more susceptible. Is that correct? Or who else is at risk, or who's at risk for eating disorders?
So I really like this question because I kind of have two answers. It's like the old me from like maybe, I don't know, 2012 or so, before like social media and all this exposure to different things for teens. And so, I think, yes, teens are a vulnerable population, right? So they can be impacted by the people in their environment, their surroundings, people they might live with. If they're seeing these kind of eating disorder patterns, that might be something that they start doing, or peers and friendships. And so certainly they're at a higher risk as you start young and noticing these kind of patterns. You're thinking about your body image a lot more and comparing yourself to your peers. So that might lead to that kind of disordered thought process during that age group. But now we have so much exposure to so many things and so much body comparison and like what you're supposed to look like, right? And so they're kind of constantly exposed to that more so than 10 years ago. And so I think they're definitely at higher risk, and it's definitely like we're in a new time where we're seeing these numbers really go up for eating disorders. So I mean, adults can get it, can have an eating disorder. Adolescents, we're seeing younger children even with eating disorders, and And the question is, why is that happening? And I don't have the perfect answer, but we suspect, right, all of these different environmental things and social things could definitely be playing a big part of that.
Yeah, I think you answered my next question, but how did you think like the social media was contributing to this? You just mentioned the cases were going up, which is, you know, I think not surprising, but any comment on that?
Yeah, every time I'm still like blown away sometimes by the teens that will tell me, I want to have lip injections, or I want, different features on my body. And they're like 12 or 13. And I'm like, well, your body's not even done developing yet. Like you might get those things, just give yourself some time, right? But it's like, us older people were thinking like, oh, we weren't thinking about those things at that young age. So a lot of it really comes down to what they're exposed to all the time. And so, I love social media for different things, or even doing this, right, is a platform for us to really share important information. And I think we just need to help guide our teams on like how to use these kinds of platforms and apps like in a more positive way, because they're so easily influenced and still their brains are still developing.
Do you ever recommend that they just go off of social media if that's a big contributor for them?
We talk about it, but the reality is they're probably not going to do any of it. And then they're probably never going to come back and see me again, because they're like, yeah, that doctor's crazy. She's telling me not to have any social media. So we just try to talk about helping them make the decision to cut back, maybe, right? If they're like, every time I go on this app, it makes me feel terrible or awful. So maybe it's like, maybe you should decide to take a pause from that app. What are the things that bring you more joy, and shift your focus somewhere else? So kind of empowering them to make the decision instead of being like scolded by, the doctors at the doctor appointment. We always know we're the bad guy in the moment, telling them things they don't want to hear. So we really try to pick and choose our battles of like, where is it that you can really make that decision for yourself?
Mm-hmm. So, I think everybody knows more or more consciously aware of anorexia and bulimia, but this new one, the avoidant restrictive, can you kind of tell us a little bit more? When did that one even get in the picture of a new diagnosis, or tell me about that?
Yes. So that ARFID for short, as we call it, avoidant restrictive food intake disorder, kind of came in around 2013 in the newer DSM-5. Mm-hmm. So before that, these behaviors that kind of fit that diagnosis certainly did exist, but we were sort of capturing that or calling that like eating disorder not otherwise specified, right? So like an EDNO is kind of vague, like, oh, there's some disorder eating thing going on, but we don't really know what to call it. It's not anorexia, it's not bulimia, but it's still an eating disorder. And so they kind of got more specific with the criteria in that newer DSM. So that really helps us manage, I think, those kids a little bit better, manage their healthcare a little bit better, because they kind of follow this pattern. And a lot of times it's not, it really has nothing to do with the negative body image or a fear of weight gain, but sometimes it's just food avoidance for some reason. We've seen kids who maybe had a really negative experience with food, like I choked on a potato chip, for example, a couple years ago, and since then I can't eat anything solid, hard, crunchy, completely avoid any solids. It becomes that extreme, and they just can't get past it, to the point of weight loss, malnutrition, relying on supplements for nutrition. So it becomes this very severe process. Or like every time I eat this type of food, I get really bad stomach pains, so that I'm just not going to eat. And so it becomes this one sort of thing that like leads this snowball effect of eating behaviors that lead you to this very malnourished state. So I can say, like, if I have that, I can say, like, I do want to gain weight. I just can't. I can't do it. I can't get past this thing. So it is still a mental health diagnosis that we would really encourage a mental health specialist, a therapist that's very familiar with ARFID, along with like speech therapy, to get them back to that nourished state. Because just saying like, here's a dietitian who's going to tell you what to eat, Like everybody's tried that already. You put that plate of food in front of them already and they're like not gonna do it.
Did you
So,
see speech therapy?
yeah, sometimes it's feeding therapy, swallow therapy. Like they have to have this kind of person typically to help them through it, but also it's like the mental health component plus the nutrition component. So I always say, like, it takes a village. You really need a lot of team members to kind of weigh in.
So I guess I wasn't as familiar with that. Like if you had previously maybe choked on a chip or something, and then all of a sudden you're terrified to eat it, like that could lead to such excessive behaviors. That's really surprising to hear. I hadn't heard of that one, but now I see what you mean with like speech, because normally in, medical world, speech and swallow go together. So if they're, like need to work up the swallowing problem, then I can see how that came. So, I mean, you obviously mentioned the multidisciplinary approach is super important. Any more comments on that or?
Yes, I can't live without my team. And I've tried. So when I first got here, I thought, oh, we'll just have like some, patients with eating disorders, not a big deal. A big part of adolescent medicine training. But I think we just kept getting more and more referrals, and I kept kind of connecting them to a dietitian and finding somebody and then trying to find a therapist. And I said, well, what if we just all work together on one day a week or so? And then it's kind of a one-stop shop for the families. And we've had such like just glowing remarks from the families. It is a longer visit. I'm not going to lie. It is probably a 2.5 hour visit, but it's because they will see each of the providers. We all really talk about the patient care plan together in that moment and share with the family. I mean, they're really hard visits. Sometimes it's the first time the family's ever heard of anorexia nervosa. And there's tears and there's stress. And like I said, we're the bad guys saying like, you got to stop exercising. You might have to stop school. You might have to come to the hospital today. And they weren't expecting any of these things. And so it's a good support network for each other, but also for the families.
Yeah, that's so nice that you have that available. Cause I mean, I mentioned to you before the go live, but I have, I coach people in weight management, and I do diagnose binge eating disorder, mostly in adults. And I often struggle because I need to refer them out to also, therapy or psychiatry. I can't be, doing everything that I need to do for them. They definitely need additional support. So having that whole team approach is pretty important and awesome that you have that. So I have another question, but what should parents or friends and family look out for if they suspect someone that they love has an eating disorder?
A lot of times people with a true eating disorder have some common characteristics. So, certainly everyone is different, but sometimes you might notice somebody who won't sit with everybody else during a meal. They kind of want to stand. You might be shaking their leg while eating. They'll cut up their food in very, very small pieces. Won't finish complete plates of food. Or very particular about serving themselves versus somebody else serving their plate. So those could be sort of some signs that something is going on there. And it could be a really hard discussion because you don't want to maybe come out and just say like, do you have an eating disorder? But you might notice the physical characteristics too, where they're like losing weight or they're not feeling well, or like you guys are all playing basketball outside and they're not keeping up with you. And those could be really dangerous signs. So, I think if you're not the person that's close with them, if you can identify somebody, you can maybe pull them aside to say like, hey, is everything okay? I've noticed some of these things. How are you feeling? A lot of times they just need that person to reach out to help them identify the problem, or just say it out loud. They know that there's something going on, right? But it is really hard for even them to talk about. And that's kind of what happens in our clinical setting is we might be the first people to actually just bring it out and ask the questions. And there's a lot more, I think, sharing than resistance. Like there's tears, there's a lot of emotion that comes with it because they know internally it's not healthy for them. They just can't get through it alone.
Mm-hmm. You mentioned weight loss, but isn't it true for bulimia, they may not have weight loss?
Yes. So for bulimia, part of that diagnosis is usually binge eating. And so like a true binge is really like eating a proportion that's like out of the ordinary, out of the normal sort of plate size. So if it's like a whole family size bag of potato chips in one setting, or the whole half gallon of ice cream in a setting, like that's a true binge. Versus we all kind of use that term casually. We ate more than we typically do in a day. We're like, oh, I binged yesterday. But a true binge is when we're eating like out of something different from like what somebody next to you is really eating. And so it's usually a lot more. And so that's where you can see that sort of weight gain come in with somebody with bulimia. But then there's typically this compensatory behavior. Like, I feel so guilty about how I lost control yesterday eating so much. Now I'm going to like either starve all day and not eat, or exercise excessively, or purge, right, to get rid of those calories that I consumed. So that's, like you said, sometimes where you see that weight gain.
And what are some signs and things that family can look out for bulimia in particular?
So sometimes families notice they're always going to the restroom right after a meal. So getting up from dinner pretty quickly, or at a restaurant, there's always like a bathroom trip. But then other physical features that you might remember too from med school is, some of those classic signs like on the knuckles, and that's somebody who is like inducing vomiting on themselves, or swelling of parotid glands, right? So you might see swelling of the cheeks. And so, you might see some of those kind of physical characteristics, but very similarly, like there's usually just different patterns of eating. So if you're noticing binges, or you're noticing a lot of restriction, and they're not kind of doing similar things in a group setting that most people would be doing, similar, eating habits at a party, for example, right? Everybody's kind of gathered around the kitchen snacking, and this person is like never in that environment. So kind of small signs like that.
So we mentioned, obviously your multidisciplinary approach, but it might be more, someone else might pick up on it first, right? So where, like if the family has any inkling that this may be going on, where should they go get help?
I think the first stop is your primary care provider. So, I think primary care providers are the front line of most things, right? That's the person that you know best, that you trust probably the most, that you've seen the most often. And so especially for adolescents and kids, parents usually trust that doctor. As soon as anything's going on, they call them immediately. So what I really try to encourage pediatricians is maybe pick that one very brief screening tool that you use. And it could be something very short. There's ones that are like 12 questions. There's ones that are lengthier, that are really specific to like eating disorder behaviors. That way, if they're completing that for you and there's some red flags on there, you can go and ask a few more questions, and then decide like, this is somebody who really needs more specialized care, or we need to really develop a plan for. But the other part is the growth chart. Sometimes as providers, we're so rushed for time. Looking at a growth chart could be last minute, or even when the patient's out the door. So really noticing that trend. If you're seeing a big slope going down, ask about it. What's going on? Is that on purpose because we're losing weight in a healthy way, versus from purging, or over exercising, or restricting severely?
Mm-hmm. So are these patients kind of doomed to have this the rest of their life, or how long do you think that they will have this problem really?
Yeah, that's a good question, and it's a common question. So I think it's a lifelong diagnosis, so it's important to share that. But I definitely would let them know the encouraging part is you're not doomed with it. It's lifelong, but you can achieve recovery, and that is success. And so, these thoughts might creep up now and again over your lifetime, but it certainly doesn't mean that you have to act on them, or that you will act on them. So building their support network as much as possible is so important. And I think just being honest about that, these thoughts might happen, but you're going to be fine. Like, you've built yourself up, you're strong, you've done it, and you're not going to act on them, right? So just empowering them again to just know that even though that's there, that's part of their history, it's not going to define them. They can still achieve any goal that they want to. And we see that a lot too with our like athletes. I think that's a big message to let them know they can get back to whatever athletic goal that they might have had, or maybe they had to stop while they were getting treatment. Like they can still get back to that.
Yeah, absolutely. So, I mean, obviously I see more of the adult population. So I do see some patients with that, and, you know, they may have gained weight later in life, and we kind of struggle to, I guess, I'm glad that they mention if they've had an eating disorder, because if they're struggling, then I need to be aware of these other, you know, habits that they've had or thoughts, really, and how we can improve, you know, the current thoughts that they have. And then also helping with body image. Does someone do work with that, or is that more the psychiatrist? Or
I think typically that gets more discussed during the one-on-one therapy sessions. So part of our team clinic is much more medically focused, but then we link them to that next treatment plan is going to be therapy. So then we kind of help decide, is it 1 hour a week of therapy for anorexia, for example, or ARFID or bulimia? Or do you need higher level of care? And that's when you're getting like more hours of therapy, more days per week, or even like a residential treatment center where you actually go to the facility and stay overnight. But typically they will address and work through those like body dysmorphic thoughts and work on self-esteem and coping mechanisms.
awesome. So is there any other advice you'd like to give our listeners about recognizing eating disorders or anything else?
Yeah, I would say sometimes we see a lot of self-blame, or especially on the parent side, like, I wish I wouldn't have said this or done this. And it's nobody's fault. So nobody caused this. Like I mentioned, it's almost like this switch goes off that spirals out of control. And so, you know, the self-blame, it doesn't help anyone, right? We just have to acknowledge it, recognize it, and then like do whatever we can to move forward from it. So I think, you know, that's just kind of maybe one message for the family side, especially because we do see that kind of self-blame a lot. And even with the teens themselves, like nothing is your fault, right? And just encouraging them that they will achieve recovery. And the other piece I would say, especially kind of going back to the athletes, is there is a difference between like the athletic heart and the eating disorder heart. And that kind of gets fuzzy so much. So I think it's just such an important message because you know, we're used to seeing a really vigorous athlete with a lower heart rate, and that could be totally normal and part of just being athletic. But a malnourished heart with a low heart rate is different. So we typically use like an example of, like, you think of an Olympic athlete, like Michael Phelps, or somebody who, like, if you I think you can Google like what he eats for breakfast or lunch or dinner, and it's like, it looks like Thanksgiving dinner in one setting, right? Like it's just a lot of calories, so he can go out there and be an Olympic champion. But that's not the case. That's not the history from somebody with an eating disorder, right? They're not eating that amount of calories and then having a low heart rate. So we often have to describe that difference. And sometimes there's some resistance on, you know, you need to be admitted today because your heart's unstable. And they're like, oh no, it's just because I'm an athlete. So we have to really make sure we understand, or help the families and the patients to understand, like, once you're all better and you're eating well and you have a low heart rate, okay. But right now, your heart rate is because of the malnutrition. So I think those two messages are what I would really want to encourage people to kind of think about and remember.
That's super important, even for me as a primary care doctor, because I don't think I've thought that about the heart rate before. Like normally if someone comes in with a low heart rate, especially an adolescent, you'd think definitely it's more athletic prowess than an eating disorder. So I will keep my eyes out for that for sure in the future. Thank you for that. Yeah. Any last parting words, or where can they reach you?
Sure. So I'm a provider here, as I mentioned, at the Children's Hospital in Tampa Bay. So it's Johns Hopkins All Children's, and we have an adolescent and young adult specialty clinic for 12 to 21-year-olds. We do a variety of care here, but one of our programs is the eating disorder clinic. And so to make an appointment, You can find us online very easily. You can call our phone number, and they will get you scheduled with us as soon as we can see you.
Awesome. Well, thank you so much for coming on the podcast, Dr. Reese. I really appreciate it. And thank you everyone for listening to the Get Healthy Tampa Bay podcast. I hope you'll join us for next week's episode. And don't forget to share with your family and friends and review us on iTunes.
Thanks.
Bye.